Welcome to the NEI podcast. In today's episode, we're coming to you from the 2023 NEI Congress in Colorado Springs, Colorado. We'll be hearing from one of our incredible speakers in this special extended Q&A episode to give you a chance to get your unanswered questions addressed from selected presentations.
Hello, my name is Dr. Jeffrey Strawn, and I'll be answering some questions related to my presentation, Along for the Ride: Treatment Considerations in Childhood Psychiatric Disorders with Co-occurring Anxiety. So the first question is a really good one, but relates to the fact that post-traumatic stress disorder was once an anxiety disorder, but now is not an anxiety disorder. That said, we're still going to try to tackle this. So the question is prazosin recommended to treat nightmares related to trauma in children and adolescents, and at what ages? So this is one of those medications for which the evidence base really lags, but certainly we are using it pretty commonly based on randomized controlled trials in adults. One of the things that really is helpful to think about in terms of prazosin is that its role is probably almost exclusively restricted to hyperarousal and intrusive symptoms, so including those things like nightmares. And there's a really nice study of prazosin in a large sample of children and adolescents with sexual abuse-related PTSD used adjunctively with trauma-focused cognitive behavioral therapy that showed significant improvements in terms of those sleep measures. The other thing that's important to talk about when we're thinking about prazosin is that it probably has a unique tolerability profile in the pediatric population compared to adults. And that is that we tend to see a little bit less orthostatic hypotension in pediatric patients compared to adults. So the next question was related to treating anxiety disorders early, and could that potentially prevent or even delay the onset of an eating disorder? Now, there's a pretty complicated relationship between anxiety disorders and eating disorders that we talked about in our presentation. I'm unaware of any data that suggests that if we treat the anxiety disorder early, we would potentially abort the development of an eating disorder, although certainly there is some evidence to suggest that this could potentially be the case. First, we know that many of the anxiety symptoms tend to reverberate with anxiety disorder symptoms. So ostensibly, treating the anxiety, or more effectively treating the anxiety early on, could, if you will, decrease the morbidity or the severity associated with the eating disorder. The next question is related to a study that we published a couple of years ago. The question states, a 2020 paper in the Journal of the American Academy of Child and Adolescent Psychiatry examined antidepressant tolerability in kids with anxiety and OCD and found that overall tolerability was better with SNRIs, but that there was more activation. So again, a very specific side effect associated with the SSRIs. Now, this is a question that is a bit challenging because the paper that the person asking the question is referring to was really focused on tolerability. And so this is one of those, unfortunately, not too uncommon situations in psychiatry where we need to potentially consider both tolerability as well as efficacy. We know that the SSRIs tend to produce larger and faster improvement compared to the SNRIs. Now, it's true that the SNRIs are associated with overall, at least in the case of SNRIs that are not venlafaxine, better tolerability. That being said, I don't think we should necessarily present ourselves with the false choice of an antidepressant with good efficacy versus an antidepressant with good tolerability. We know that there are strategies that we can use in terms of dosing the SSRIs, again, that class of medications with the greatest and fastest improvement in anxiety, that can hopefully help ameliorate some of those side effects. So these include things like slower titration, more frequent monitoring for side effects, individualizing dose based on individual factors, etc. Now, the next question relates to guanfacine extended release versus immediate release. And the question asks, is guanfacine XR or IR better to help with anxiety? Certainly, this is not something that we have data from randomized controlled trials, but one of the things that I mentioned in my presentation is that there really is a pharmacokinetic difference between extended release guanfacine and immediate release guanfacine. That is to say that the extended release guanfacine is going to tend to produce lower blood concentrations over time and a lower peak compared to the immediate release. The other issue is that we really need to be careful in terms of not substituting on a milligram per milligram basis guanfacine IR and guanfacine XR. Now, the next question is, would you ever use clonidine and guanfacine in the same patient to catch all three of the alpha-2 receptors? Let me take a step back in terms of the synaptic physiology, if you will. So in thinking about clonidine, we're going to hit alpha-2A, 2B, and 2C. Guanfacine is going to be a little bit more selective in terms of only affecting alpha-2A, which again probably gives rise to less sedation in patients treated with guanfacine. Now, I'm very, very, very cautious. In other words, probably I don't recommend using two alpha-2 agonists or really two antiadrenergics in the same patient at the same time. I think there's really just too much potential for worsening of side effects or confusion in terms of dosing and so forth. And so I really would probably try to stay away from clonidine and guanfacine in the same patient. Now, the next question is there any research on amphetamine-based stimulants and anxiety in ADHD and anxiety disorders? So the question is correct in that I mostly focused in my presentation on methylphenidate-based treatment. With regard to the amphetamine-based medications, I'm not aware of any studies that we have in the pediatric population that actually look at the effects specifically on anxiety. That being said, there is a nice meta-analysis by Michael Bloch's group, which I believe was published in the Journal of Clinical Psychiatry. And what it showed overall was that there was a worsening of some emotional symptoms, including irritability, in patients treated with the mixed amphetamine salt-based stimulants compared to the methylphenidate-based stimulants. And so for those reasons, in a patient with ADHD plus anxiety, I tend to use the methylphenidate-based preparations as my first-line medication. So the other thing that's important to consider here is that when we're thinking about methylphenidate and amphetamine-based medications, we really have groups within groups. And so for methylphenidate, we certainly have the racemic mixture, but we also have isomeric formulations. And similarly, we have the racemic amphetamine-based preparations and racemic amphetamine. In general, some studies suggest that isomeric formulation may have overall better tolerability and a lower risk of side effects. Now, the next question is focused on how do you select an SSRI in pediatric patients with anxiety disorders? And this is really a complicated question. From a pharmacologic standpoint, we don't have evidence to suggest that one SSRI is better than another in terms of efficacy. So for me, what this really then comes down to is how do I evaluate the evidence and the studies that have evaluated sertraline, escitalopram, fluvoxamine, fluoxetine, paroxetine in kids with anxiety disorders. And here it's not a difference in efficacy that really distinguishes them, it's a difference in tolerability. And so for this reason, I tend to use sertraline, escitalopram, and fluoxetine similarly, but tend to avoid, as many of our listeners probably do as well, paroxetine because of its potential to worsen suicidality, its potential for anticholinergic side effects, as well as just its complicated pharmacokinetics. Now, the next question is, are there any specific assessment tools that can aid in identifying children with co-occurring conditions? There certainly are. So I do like to include some measure of depressive symptoms. I often will use things like the quick inventory of depressive symptoms But I will also, in assessing the anxiety symptoms, tend to focus on the SCARED. And there is a shorter version of the SCARED. So that's the Screen for Anxiety and Related Disorders in Children and Adolescents, the SCARED, published by Boris Birmahar and colleagues. And that instrument is really nice in that it allows a clinician to look at different types of anxiety symptoms, so separation, panic, social anxiety disorder, etc., and also includes response thresholds for treatment. So we can use this to look at how effective our treatments are over time. I tend not to use a screening instrument for ADHD beyond the Vanderbilt, and I tend to use my general clinical assessment to assess other comorbidities. Now, the last question is, how can healthcare professionals and caregivers better collaborate to ensure that interventions for children with co-occurring anxiety and psychiatric disorders are effective? And this is probably the most important question we have. I think it's really incumbent on us to try to collaborate with everyone who's involved. That psychotherapist who's seeing the patient is spending substantially more time with the individual, perhaps than the psychiatrist or psychiatric nurse practitioner or the psychiatric clinician seeing that patient. Similarly, that teacher, depending on the age range, may be spending 6 hours with that individual over the course of the day. And this is a situation where I really think it is important, because oftentimes if we see anxiety that's primarily present in one setting but not present in others, that should be a red flag for us, not necessarily in terms of changing the treatment, but in terms of thinking about some of those other factors that may be situationally specific. So perhaps there's a learning disorder that is making the child more anxious at school and looking like a worsening of anxiety. Perhaps it's co-occurring ADHD that is making the child more anxious at school, etc. So it's really been a pleasure to go through these questions and to spend a little bit more time delving into the details of comorbidity in pediatric anxiety disorders. Thank you again.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.